Okay, very good session. We're getting a little bit more into some controversies and a little bit more into some surgical areas. Any questions right offhand? Because I've got a bunch of them.
Yes.
Okay, first of all, yes, Philippe.
One first question to Philippe about more a reaction to your phrase. 2 screws are mandatory in the Latarjet procedure. I disagree, but I have no proof because there is no evidence to show that 1 or 2 screw is better currently. I believe that I used to use this 2 screw, but now I don't use anymore and use only 1 screw with a washer and a compressive screw because I think that this technique with this 2 screw decrease the amount of bone contact between the which is a concern. And in addition, it creates a sort of line of weakness favorable to a possible fracture. And I know that people advocate the 2 screw to decrease the risk of rotation. And I'm not sure it's really an issue. What do you think about that?
But you take a long bone block, the same bone block, 1 central screws. My only consider would be rotation. This is my only consider because you have the conjoint tendon pulling in the inferior part, and it might finish with the bone block which is proud, which is not at the level of which is above the level of the cartilage. This is the only consider, and then the only thing is that I'm so afraid of having bony problems that I just follow what the rules has been. But
I think in general we like 2 points of fixation because of the rotation, and I'm going to get into that about the AC joint. Same thing. Pascal, of course, he does vertical, and he puts 1 screw in there, and he has he reports a 17% failure rate with that single fixation point.
And I have a comment on the washer thing. I was very careful using a washer if you do a Latarjet because the big washer will impinge on the cartilage on the human head. That would be very dangerous.
Philippe, I have a question for you about this metal piece of titanium you put in there. It's not bone. Well, what happens to it after a while?
Pardon?
What do you think is going to happen to it after a while? It's not bone. It's going to sit there, and there's going to be torque on it. And there's, you know how many screws you put in there. What's going to happen to that piece of metal on the front of your shoulder?
But anyhow, you will put screws. You will put metal in the anterior part of the shoulder if you do a bone block. But I just need this implant for 2 years until the soft tissue are healed. I've healed.
And then
it is the idea. The idea is to enhance our bank card repair.
Yeah, good luck. We really want to see the results on that. That's
Me too. Me too. It's a bet. It's truly a bet. Because if you look at the result of Herbert Resch and Marcus Scheibel, without any conjoint tendon, they have the same results as the Latarjet. Exactly the same result, and they don't have any conjoint tendon.
Yeah, E.G., you showed some data that suggests that the conjoint tendon does have a role. My own thought on it is that it's more of the diameter myself and less of the sling. That's what I've always felt. But your data shows that it's a very important part of stability.
Yes, using cadavers with the arm in abduction and external rotation, the sling has a very important role in the at the end range of motion. It's about 70%, or in the mid range, it's about 60% or something. So I think the sling has a very important function, especially in the mid range. The more force you apply to the sling, the more stability you can obtain. So in the mid-range, like holding your arm here, if you apply force to the conjoint tendon, it will stabilize the shoulder.
Okay, so hopefully
I totally agree with AG, but when I have done surgery in revision case, 5 years, 10 years after a Latarjet doing a shoulder replacement or anything else, you never find the conjoint tendon.
I agree entirely, yes.
Never.
Yeah, question in the very back.
You mean it disappears?
Was-
With tenodesis and tenotomy, we know the biceps plays a role in stability of the shoulder. Don't you worry that with doing that, we have some complications, more stress on the other stabilizers in the shoulder that can lead to other possible tendinopathies or other issues in athletes?
The question is, what happens when you move this? You know, one of the things about the coracoid, the reason why the coracoid is where it is, and the biceps tendon attaches where it does, is to give a little bit of a mechanical advantage to the biceps tendon. Now you're turning it, laying it flat, putting another position. Is there a change not only to the elbow but also to the shoulder? And I don't think there's been any studies to look at truly, for example, supination strength of the individual who's had a lateral J procedure, for example.
Yes, I think if you do the tenodesis of the long head of the biceps, you sacrifice the function of the long head of the biceps to the shoulder. But if you do the tenodesis to the short head of the biceps, you can still keep that function. But the problem is the short head and the long head of the biceps has different functions in terms of movers. Short head is an adductor, long head is an abductor. So you can increase the function of short head, but you still have to sacrifice the function of the long head of the biceps. But I don't think there's any way you can keep the function of the biceps to the shoulder, except you put the tendon back to the superior glenoid. But I don't think that works.
So there's a question of whether or not, and the short head of the biceps does have more motor power than the long head. So the question is, are you even sacrificing more by moving it, even though you're still stabilizing it, you're putting in a mechanical disadvantage relative to where it was?
I don't think there's any study.
There's no studies on this, but that's always been a concern of mine. Yeah.
I have a first question, Dr. Hardy, to you. You show us that lateral J operation have done 100% good results or excellent results, and I agree completely with you. My question is, you are going to change a technique, and you are showing us that you are going to do it by arthroscopy, that you are introducing now new
Materials.
metallic material. Why are you doing that when you have 100% excellent result?
That's a good question. First thing, 100% on dislocation. The paper of Alain, there's no word on arthritis, nothing on subluxation, nothing on apprehension. So I think they are a little bit optimistic. There are no dislocation for sure. They're not liars, but that's 100% excellent result. First thing. Second thing, I'm really concerned about the 30% of complication on the X-rays. Although you have good clinical results, you have a 30% complication in terms of fracture, non-union, lysis. And when you have a failure of a lateral J, then you have to go for big surgeries. Failures of lateral J are difficult surgery to deal with. You have to deal with, take a iliac crest, you have to do graft or heel sac lesions. I know that some surgeons are saying I do a pushed indication of arthroscopic Bankart. If I have a failure, then I almost have a virgin shoulder. I can do whatever I want. So this is the problem: is that lateral J if you have a failure of lateral J, it is big surgery. So my idea is that if my implant is having failures, then you can do whatever you want. You still have your coracoid process.
Okay. Yes. Go ahead.
Can I ask a second question to you concerning acromioclavicular dislocation? Acromioclavicular dislocation grade 3, and after we are talking 4, 5, and so on, but basically that was discussed and operated in past 25 years. And we try everything as different technique. I don't know how many was described in the literature. But other sides, I was a throwing athlete and I played handball 20 years. No of my friends was operated and all of them continue to play. And you are not frightened with your arthroscopic technique with these 2 canals that you are going to have of stress fracture. For example, in handball players who have to come back very early and who is going to fall 50 times per match with his 100 kilos of that he don't have some fracture.
Yeah, thank you. This is why that I prefer, although I don't think Rockwood classification is perfect, but I prefer more for Rockwood classification. For Almontosi, he attributed the type 3 that was included in the Rockwood classification is type 3, 4, and 5. For me, the most indicated surgery for the type is type 4 in the Rockwood, where the distal clavicle piercing backwards into the trapezius. That was very painful. It's very disabling. So this is the most cases I've done. And most of the other is type 5. I agree that in high contact sports, it will be a problem. But in that kind of patients, it is not the fracture of the tunnel bothers me. It is the redislocation bothers me. I think in that time, because my tunnel was only 4 millimeters, is widespread, at least 2 centimeters away. And that 2 holes, I don't think they will sacrifice a lot to the bony structures. But I still worry, I totally agree with you, that if there's very high-level contact sports athlete, they will be redislocated. The reconstructed ligament will fail first, rather than the fracture of the tunnel. That's my opinion.
I'd like to expand a little bit on this. The East Coast Upper Extremity Committee has looked at this, and we did a position paper, and it was presented at the East Coast meeting in Toronto, and it's going to come out in arthroscopy. And EG was in charge of evaluating this, and we realized that this classification system is no good. I'll just say it. It is no good. It doesn't have any, those 4 A's I listed before, it fails all 4 of the 4 A's. And so we looked at the biomechanical reason for what this is going on. I can give you on x-ray, I can give you a type 3 or a type 5 depending on how I put your arm. So that means the plain x-ray, even if you get an orthogonal view, tells you nothing about the dynamic problem that exists or how you treat it. So we came up with basically a classification of the 3s, or 3A and 3B, and basically has to do with whether or not the AC joint is doing what it's supposed to do. What's the AC joint supposed to do? It's providing a stable screw axis for the scapula and the arm to move as you put your arm in overhead position. And you can do the Basmania X-ray, which is a horizontal adduction X-ray, which allows you to see. Remember, it's not the clavicle that's the problem. It's the scapula that's the problem. It's going down and in. Clavicle's not going up. The scapula's going down and in. And that's what gives you the bump. That's what gives you the trouble with your arm. That's what gives you the biomechanical problems. And so you can either do the X-ray or you can actually, let's look at the patient. Let's look at the patient, okay? Let's see if his scapula is sitting in a funny position. It turns out that from Italy, they did a study on type 3s, found out that 1/3 of the patients showed no scapular dyskinesis and 2/3 did. Now that tells you that there's a biomechanical issue with the ability to use the arm. So E.G. and his group, and I was in part of that, and Gus was, and Guillermo, and say that if you look at the patient and look at the scapula, if they're bad, that's the type 3B. If the scapula looks pretty good, then that's the type 3A, which means that you've got some ligamentous, even though you still see this little rise. Then now you have an idea of when you want to operate on these, is when it's unstable or not. And the other thing is, remember AC ligaments. AC ligaments exist for a reason, anterior, posterior. If you're going to fix one of these things, do your CC ligaments. And why do you have two CC ligaments? To control rotation, 2-point fixation. So you got this one single tightrope. That's why you get the 17 or 20% failure of the tightropes by themselves, because you have one single plane of fixation rather than the two. But also, once you fix that, be honest with yourself and look at your anterior-posterior travel. You'll find that a significant number of patients will still have anterior-posterior travel of your AC joint. Therefore, you have to do something to the AC ligaments as well. Gus and I now are doing this, where we're actually using exactly the same technique. I'm doing open. It was mentioned here about the two holes around the clavicle, around the coracoid, but we're also bringing them laterally and reconstructing the AC ligaments. And a lot of times these type 4s, the reason why it is that way is because the posterior AC ligaments are actually stuck in between the two bones. It may be that it's gone through the fascia, but more often it's the ligaments are bad. The posterior AC ligaments are actually stuck between the two bones. You got to get those out of there and repair them as well. AC ligaments are very important to fix it that way as well. So those are some other points about that. We run out of time. How are we doing on time? Good. Question.
A question to Dr. Jana and to Philippe. Sometimes the sexy operations are not as good results as the open one. For example, the arthroscopic AC joint reconstruction in the acute scenario. The problem with the scope is that we perform a lot of them, about 30 of them, arthroscopic reconstruction, and in the acute, you have to resect the stumps of the ligaments. So with the open technique of Gasman-Soka, you can preserve the trapezoid and conoid. And through the scope, you have to resect the ligaments and put the graft on. That's one question. And the other question to Philippe is, it's hard to see some perfect bunker reconstruction. Do you think that the arthroscopic letter J is in the future will be the next step, or is an operation that will never be well done by the general orthopedic surgeon or even the better shoulder arthroscopist in the world?
So I'll get the first question. I think, in my hand, I think you don't have to remove all the stumps. I can do, you debride all the hematomas away with a very control of blood pressure and your pump. You can see very clearly of the stumps. And I can do drill my tunnels just medial, posteriorly, and lateral anteriorly along the remnant. So that's for me like a sandwich technique. So that doesn't bother me. So I don't remove all the stumps.
Well, the problem is you have a harder time doing anything, the AC ligaments with a scope.
Right.
And therefore I do it open for that reason. Philippe?
For the arthroscopic letter J, you cannot say there's no future for the arthroscopic letter J. It's impossible. I don't know any surgery when you start arthroscopically and it stopped, and it was doing less good than open. So, but for the moment, it's a technical issue. One of my former fellows there, Dr. Meyer, and he used to do a lot of arthroscopic letter J in the department, and he was doing fine at the end. He was doing quick procedures, fine, but it's really a long learning curve, and it's a technical problem. It's only a technical problem, and I'm sure we will end up with some simple system being able to do it. So there's probably a future for this. The problem is that is it ready to be widely released? That's another problem. There are some studies coming now with a high number of complications.
I've done that arthroscopic lateral J for about 2 years, now finishing about 40 cases. I think Philip is right, he's got a long learning curve, but I think I've spent my learning curve in arthroscopic CC reconstruction. It's a very good way before the arthroscopic lateral J. When you finish about 100 or 200 cases of AC dislocations, you get everything clear for the anterolateral shoulder. And you have managed around the coracoid, so there's a great help to do a CC reconstruction under the scope before the scope lateral J.
Okay, one final question to Guillermo. If we're getting pretty bad results on these slap repairs, why is that? Is it because it's a bad diagnosis? We're not making the right diagnosis of the right patient? Is it bad surgery? That we're not putting the anchors where we're supposed to put them, we're using the wrong type of material, we're tying it down the wrong way, or is it bad post-operative rehabilitation?
Mainly, my view is a bad diagnosis. The painful shoulder in a young athlete, all of us think about slap, and we are there. It's very easy to put the anchor and to deliver the knot. So I think that perhaps we are operating on slap that they don't need to be fixed. I think that the problem is diagnosis. It's not the surgical techniques. There are better surgical techniques. You can put a mattress stitch longitudinal in order to get the meniscal labrum. But sometimes for surgeons, it's not easy to make a partial, unstable superior labrum for a thrower. It's easier for us to reconstruct the anterior-inferior labrum that we can go as stiff and as stable as we can.
Exactly right. Okay, and you set me up for this my talk this afternoon. But the idea is that we're not doing a very good job of figuring out when we should put our anchors. Everybody can put anchors in anywhere. Okay, it's when should we do it? That's the big deal. And then what we do afterwards, after we put those anchors in, we wash our hands of the case and say, okay, you therapists, have at it. And that's not right either.
And also the superior labrum has to move like a meniscus.
Exactly right. It has a tension band. It has a motion right here. You cannot use fiber wire. You cannot use those kind of things. You
Would you
cannot tighten it down.
Would you fix the lateral part of the meniscus to the bone? That's what we are doing when we do a superior labrum repair.
Yeah. Okay, thank you.